What is going on? Monday. Happy Monday. Hopefully everybody had a good weekend. Back at it with a live case. Case of the day. I guess we can kind of start off with the pre-case of the day, which was just me showing a cup of coffee, and I happened to catch a sequence in the back on my monitor, and I just wanted to kind of keep your guys' brains jogging a little. It was almost split, and then some people actually, or a lot of people wanted a refresher on what kind of sequence that was on my monitors in the back. So let's go. Quick refresher. My rules of thumb for MRI, depending on if you're a radiology resident, you're going to want to know all the sequences of MRI, obviously. If you are not a radiology resident, or if you're a medical student not really wanting to go into radiology, I'm going to answer both of those questions and kind of basically give you a general rule of thumb of what to do. So let's go off with, if you are a radiology resident, you are looking at a coronal haste image, non-fat saturated. That's what was up behind my screens on the image today. T2. Let's go. Radiology 101. How did we know that was a T2 image? The three things that I always look for to tell me if it's a T2 image. 1, look at the gallbladder. Number 2, look at the CSF. Number 3, look at the actual bladder. If you can see any one of those three and it's bright, it is a 95% chance that is a T2 image. I'm saying 95% because there is a caveat. If anybody can tell me what type of sequence does have bright what kind of sequence does have bright CSF, gallbladder, and bladder, but it's not quite a T2 image, hey, shout it out. Otherwise, if you're, just don't worry about it. That's not important. Remember, 95% of the time, if you see, recap, gallbladder, CSF, bladder, if they are bright, it's a T2 image. The reason that I keep stressing T2, if you're a non-radiologist, you don't really care about any other sequences. The only sequence that you want to know is a T2 sequence, fat saturated. I call that the itis sequence, ITIS, with a little dash in the beginning of it, because that tells you where the inflammation is. T2, let's just go. Let's break this down real quick, and we'll bring it full circle as to why the non-radiologists care what a T2 image is. The only reason that I always love giving these little caveats. Yes, the main reason that you want to order an MRI is because you think something is inflamed, right? You think the liver's inflamed. You think the bladder's inflamed, the kidneys, the bowel, whatever it is. You think something's inflamed. So you're like, hey, I'm going to order an MRI, okay? So T2, the two things that are bright that I care about on a T2 image, 1 is fluid and number 2 is fat. Yes, there are other things that are bright, but the main two things that are bright on a T2 image, fluid and fat. Therefore, when I tell you as a non-radiologist, the only sequence that you care about is a T2 fat saturated sequence. Therefore, you are satting out the fat. Here's fluid, here's fat. I sat the fat out. The only thing that is left is fluid. Hey, guess what? Things that are inflamed have a lot of fluid around them. So you're going to look at this dark image. The liver is going to be dark. The spleen is going to be dark. The bowel is going to be dark. Everything is going to be dark. But then you also looked at the bladder, you looked at the CSF, and you looked at the gallbladder, and you're like, wait a second, those three things are bright. Everything else is dark. I remember what Amrit told me that one time, is that I only care about the itis sequence as a non-radiology resident or a non-radiologist. So I'm going to pull up that sequence, and I'm just going to go around and I'm going to look for some bright things. I'm going to go down to the right lower quadrant and I'm going to see something bright. Occam's razor, I've mentioned this before, the simplest answers are usually the actual answer. Hey, right lower quadrant, patients having pain in the right lower quadrant. There's a bunch of inflammation on the itis sequence. It's probably appendicitis. Yes, it can be other things, but I'm just giving you a general rule of thumb. Go by it. Hey, you know what? The guy's complaining of dysuria. He's complaining of some fevers. I go to my itis sequence, T2 fat saturated. You know what? The kidneys look really bright. For some reason, there's some fluid around the kidneys. You know what? Go for it. It's an inflamed kidney. Yes, somebody can tell me it could be an obstructing stone. It could be physiologic fluid. But you're the clinician, the non-radiologist who has the labs, who has the actual physical exam. Go with your gut, or just wait for me to read it, right? So that's the T2 sequence. Remember, recap. People joining right now, you're a non-radiologist. You care about the only abdominal MRI sequence is a T2 fat saturated sequence, okay? Look at the gallbladder, look at the bladder, look at the CSF. Any of those are bright, it's a T2 sequence. Boom, thank you. Let's go to the actual case of the day, case of the 2 days. My bad from Saturday. By the way, I didn't have a case of the day up. I got called out hard. So I made sure to put in a 2-day case of the day starting yesterday. Carried it on over today, case of the 2 days. Let's talk about it. Let's discuss. So the first thing that I put up was this bad boy right here, right? You guys all remember this. What is the one thing that's sticking out to everybody's mind or eyes, whatever you want to stick out to? It's the small bowel, right? Wait a second, Amrit. How do I know that this is small bowel, right? Because I actually asked that question too. I think it was split down the middle. Actually, maybe small bowel was a little bit more than large bowel. But there's a lot of confusion as to what is small bowel and what is large bowel. 3 seconds. Who wants to chime in with my characteristic drinking water? Who wants to tell me why large bowel is large on a KUB? How do I know? And how do I know small bowel is small bowel? Hostrations. What does that mean? That's a fancy word. I like it a lot. But how do I know something is a haustra or haustra? Somebody want to correct me how to say it. On a KUB, how do I know? And contrary to haustral folds, what's the small bowel equivalent? Who wants to toss that out too? Clever. Sorry. I guess I am, huh? Okay, so haustral folds. Do I have haustral folds on this image? Shoot, that is one image that I forgot to. VC, somebody, see, Pinky, she's smart. Pinky, correct me if I'm wrong. But radiologist, she has good answers. Remember, I'm a neuroresident now. Oh, right. Sorry, Miriam. My bad. You are. Here's a haustral fold, maybe right here. If you look at the haustral folds, you're gonna see that they're thicker than the folds in the small bowel, and they only come to about a third way of the bowel. They don't go all the way across. Remember that. Haustral folds do not go all the way across. How many times do I gotta repeat that? Do not go all the way across. VC, as somebody mentioned, is valvulae connivente or plica circularis, whatever fancy term you want to use to look cool in the reading room. That's up to you. Those are thinner lines. Let's give you a good example right here. Those are thinner lines, I can't speak, that go all the way across. All the way across. You can see all the way across. Remember, haustral folds, thicker, do not go all the way across, about a third way through, and you'll get one on the other side about a third way. Plicae circularis, valvae connivente, blah, blah, blah. They are thinner lines that go all the way across. Number two, how can you tell? General rule of thumb, yes, there's caveats, blah, blah, blah. The large bowel will sit in the periphery of the KUB. The small bowel will be in the middle of the KUB. Yes, some people do have some redundant sigmoid colons that kind of do one of these, and then they go up, and you have like this large bowel sitting in the middle. But yes, that does happen. But I'm giving you rules of thumbs here. Lots and lots of rules of thumbs. What else about those? I think that's it. So that's how I knew this was a small bowel loop on the KUB and not a large bowel loop. If somebody wants to go into USMLE stuff, then you can talk about which ones have, concentric musculature versus tinea coli. It was on the large bowel. And I think somebody correct me if I'm wrong, but I think large bowel doesn't have peristalsis. It's in the tinea coli that actually constricts. I may be off. That was a long time ago. That's just something to get your memory jogging here. So I know it's small bowel. Somebody wants to ask me how or what are the measurements for obstruction? How big can these bowels get? Because I got a lot of answers of small bowel obstruction. Sure, absolutely. You need to think about obstruction in a very systematic way. First of all, large bowel obstruction, yes, it does happen. It's not as common as small bowel obstruction, okay? So if you think there's a small bowel obstruction, you're going to see everything proximally dilated up, and then everything distally is probably going to be not as dilated or completely collapsed, depending on how severe the obstruction is. I cannot speak today. This is what happens when you drink like 4 cups of coffee today. So if it's a partial small bowel obstruction, you may have some stool, some liquid stool, some feces, blah, 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 going down distally, and then proximally it will still be dilated. If it's a complete small bowel obstruction, high grade, all those fancy terms, you may have complete collapse of stuff distally and then proximally be all ballooned up. Number 2, what I want to get to, the other thing, oh, that's right. I was going back to the diameters. What is normal caliber for small bowel, large bowel? And I want to ask you, what is the largest part of the large bowel? When do surgeons start getting concerned when this portion of the large bowel gets way too big? Anybody? You know my general rule here. I ask you a question and I drink some water and try to waste some time here. So small bowel, duodenum, that's a good guess. Cecum comes in again. There you go. Cecum is the largest part of the large bowel. Okay, it's the big ball sitting in the quadrant that has the terminal ileum going in and then the appendix on the other side. That's the cecum. Okay, so the cecum, if it gets to like 12 centimeters, then a surgeon's going, whoa, something's going on here. That thing's pretty big. I may need to intervene. This thing may need, or it may pop, and you don't want to have feces peritonitis. That's bad. That can lead to some really bad stuff. So going back down to the normal, upper limits of normal, where you start getting kind of concerned, caliber of the bowel loops. Everybody knows the song 369, right? You can start singing it in your head. I'm not going to do it right now because I have a terrible singing voice, but I do it on occasion. I do go karaoke. So 369, that's the way I remember it. Small bowel, 3 centimeters. 6 centimeters is the large bowel. 9, you get to the cecum. There's your, and you won't forget this just because you're going to imagine me singing the song now, right? So those are your upper limits of normal. Once you start getting above that, you start to get concerned. You may, ask for a CT if you're only looking on KUB. And then on the CT, you can kind of judge, hey, maybe this is not really an obstruction. It may be an ileus, maybe like a little focal ileus. It may be completely normal for the patients. So we don't know. Now let's go back to the KUB right here. Okay. Everybody talked about the small bowel loops or some sort of bowel loops, and they said we're dilated, it looks obstructed. And then I ask, is this the most concerning finding on here? The answer is no, okay? Yes, it's obstructed. Yes, they could decompress it, put an NG tube down. If they need to be surgerized, they can absolutely surgerize it, but that's not the most concerning finding. This finding that I'm about to talk to you, pretty much the patient's probably going straight to the OR. They may get some cross-sectional imaging, but I want you to take a look. Let's deal with this loop right here first, okay? You see this is all lucent meaning darker. All this is lucent right here because this is the air within the bowel, and then all this is it's a lot brighter, right? This is a lot of soft tissue, whether it's inside, fat, something, but it's brighter. So I have dark, brighter. This is the wall of the bowel right here. How many sides of the wall do you see? I only see this side of the wall because the other side I can't really see because it all blends into this brightness right here, right? Now I want you to contrast it to that bowel loop right there. I have dark, I have this white line, and then I have dark on the other side. Now I ask you, how many sides of the bowel loop can you see here? How many sides of the wall? I can see this side, and I can see this side. This is what you call Wrigler's sign, okay? This is free air. This is intraperitoneal pneumoperitoneum right here. This can be very, very subtle, but this is a surgical at least consultation. There, and I'm giving a little caveat again. There may be some instances where it's okay. But surgery needs to get involved. This could be a perforated something, but this is wriggler sign. So you got to remember that. I blew it up here. I don't know if it projects as well. I think it actually does. So lucent, you got the bright line and you got lucent on the other side. Wriggler sign. Look at all your KUBs now. Look for this. And the reason that our knee-jerk reaction when we're looking for free air is we're going straight to the hemidiaphragms. Our eyes are going up there, and we're like, well, I don't see any air there. I don't see any air there. Good to go. Let's call it negative. Absolutely not. Remember, a lot of these patients, they're not healthy 25-year-olds who are walking into the ED going, oh my God, I think, my bowel burst, and they're standing upright. They're not sitting there they're not standing upright taking that KUB image. A lot of these patients are in the ICU, obtunded, sedated, tubed, no clue what's going on. They're getting serial KUBs. A lot of these are incidental because they're trying to put the Dobhoff tube down. I seriously drank way too much coffee down today. They're trying to put the Dobhoff tube down, and they get repeat KUBs. For bonus points, somebody please tell me where a post-pyloric Dobhoff tube, usually it should sit if they want to start feeds, if the patient is a high aspiration risk. Please, somebody tell me that. The other thing, so yes, it's not an upright patient that I'm looking at on this exam. This is actually a supine patient, and you have to remember, what does air do? Why do we always look for the hemidiaphragms to check for free air? Why on a chest x-ray are we always looking for the pneumothoraces up here? Because these are upright exams and air rises, okay? So if this patient's supine, you imagine he's laying down flat, the air is gonna rise. So in a supine film, it's gonna go up to the top of the intraperitoneal cavity. So remember that. This is a secondary sign of, you have to look for wriggler signs, the bottom line I'm trying to get. Going back to what I was talking about, a post-pyloric feeding tube. Think about the ligament of Treitz. I do this every single time for people who've been watching my videos from day one. What does this represent? It's the duodenum because it makes the duodenal sweep. You want to see your Dobhoff tube making that big sweep, and then you want to see it going back up. What is a ligament of Treitz? It's basically a ligament that connects the crus of the diaphragm to the duodenal jejunal junction. So you want your post-pyloric Dobhoff tube ideally at the ligament of Treitz. So where was I? I just went on this crazy tangent. Oh, we were talking about wriggler sign. And then I put up Case of the Day Part 2 today, and I gave you another KUB. It was actually a babygram, if anybody looked at my video last time, and I mentioned, let's just pull it up so I can refresh you guys' memory here. Well, I kind of truncated it here, but the image originally went way up there and it went way down there, and I told you that on adult patients, you're never going to see it go that high unless it's a scout film. But I did say the only time that it'll go from way up here to way down there will be on a baby, because the plate, the x-ray plate, is actually big enough to accommodate the baby. So this was in a babygram, or a large, just crazy large x-ray that covered the chest and it covered the abdomen. So that's what I put up secondarily. On today's Case of the Day Part 2. Does this even project? This is like so bright. Actually, I'm looking at my phone. It does. You guys see this right here? See this bright line right here? All right, I gave you a hint. Anybody into football? This is a football sign. All right, it wasn't the Super Bowl sign, in case somebody was thinking that. This is the football sign because this is the falciform ligament. If you can see the free air, it's kind of like this lucent. Oh, shoot. There we go. You can see this free air is kind of like this lucent area, and then you see the falciform ligament going down, and you see the ribs, they're kind of making the laces of the football. That's football sign. So that's another sign that you can look for instead of wriggler sign for free air. What's next? I wanted to talk about, these cases, by the way, that I picked for yesterday and today. Shout out to Radiopedia. I grabbed them from their page. They have awesome stuff. I literally reference them every single day when I'm at work. What else? Oh, hey, somebody is in the ICU. You can't get an upright film because they can't sit up. You can't really tell that they have any free air on a supine film. What way can you roll the patient to see if there is free air? Right lateral decubitus or left lateral decubitus? What do these words even mean? Left lateral decubitus, right lateral. So when I say left lateral decube, that means I'm rolling the patient to their left side. So their left side is going to be down, it's going to be flipped on the screen, but this is my left. Left side is going to be down, the spleen is going to be touching the bed, and the liver is going to be up, facing up in the room. Why is that important? Because you want the air or the free intraperitoneal air or the pneumoperitoneum, I don't know how many different ways I can say it, you want it to be outlining the liver dome. So you want it to be kind of like, I can't really roll and hold the camera at the same time. But remember, left lateral decube is how you check for free air on a patient who can't sit upright. You can't really tell on a supine film. The other thing that I want to stress today is when you check, so you ordered an x-ray, a KUB, you think there's free air. You're like, I don't really know. So then your attending tells you, hey, why don't you order a CT and then we'll know for sure. So people are going to order the CT and they're going to keep it on abdomen window and they're going to scroll through the CT and they're going to be like, no free air. When I say abdomen window, that's the window that you're looking at the liver with, you're looking at the kidneys, you're looking at the bowel, you're looking at everything. And it's this kind of just general window. And when I say window, that basically means how the image looks. It's not too bright, it's not too dark, it's kind of like in the middle, and you can actually make out different structures. That's not how you check for free air. Please, please, please do not check for free air in an abdomen window. You will miss it, I guarantee you. Let me pull up an image here. This is how you check for free air. I just truncated it, but this is the lung window, okay? You check all your lung parenchyma, you look for your pneumonia, you look for your atelectasis, you look for your whatever you're looking for in the lung. You use this window. This is the same window that you use for intraperitoneal air. I guarantee this is a lot of free air right here. If you had it in the abdomen window and it was not a good day for you, you'd blow by this in a second and you'd be like, no, he's good to go, send him home. If anything that, and I'm gonna get to this when we're talking about PEs one day, because that's a windowing issue as well. But when you're checking for free air on CT, look at the lung window. God, is that it? I think that's it for today. I think I missed a bunch of questions. Let me just go back. If anybody wants to type up some good ones right now, let me know. Was it hard to learn to read scans? Oh man, reading scans is it's an everyday thing. It literally is. No matter how many scans you've read, you're gonna learn something new every single day. It was hard. I don't want to say hard or easy. It was a steep learning curve. In the beginning, the learning curve gets a little better the later you go, but you still get humbled every single day you go to work. There's stuff that will pop out that you never knew existed, and you just, it's a whole different experience. What else? I'm just reading right now. Somebody asked, can you do cardiac study as an interventional procedure? I am working on some cardiac stuff right now. What else? Somebody's going to bed. Hey, good night. What is a pyloric feeding tube? I think you may be saying post-pyloric. That's just, people like when I say post-pyloric, a lot of people like the aspiration risk patient to have the Dobhoff tube way past the stomach, way past the stomach. Remember, if we did talk before, and I'll do it again because now I'm starting to save these all on YouTube, but we talked before about G tubes versus GJ tubes. J tubes, Dobhoff tubes, push type, pull type. If you guys don't remember that, I'm gonna do it again for you, and I actually got some G tubes that we'll look at in real time, and I'll post that on YouTube soon. What else? Anything else? I appreciate it. Great teaching and explanations today. Thank you. Not thank me, thank you guys. I seriously, I love doing this, and I'm not doing this for any other reason other than I want you guys to I want you to learn radiology. Let me just give you a quick little kind of tangent here. Well, and I've said this before too, I don't like it when somebody leaves a reading room, a med student leaves a reading room, or another resident from not radiology, or whomever. They leave a reading room and they go, man, that was so boring. it hurts me, and it's not reflecting negative on the student or the resident who left the room. It's the job of the radiologist who is sitting there teaching. And I have a passion for it, and I want you guys can see it. I do this every day for you guys. So when I hear those kinds of stories, it just cuts deep. And that's what I'm trying to fix. Peg tube placement confirmation. How much contrast do you suggest using? Oh, it's variable. It's really variable. How much have I mean, I've done as little as a couple of cc's of contrast, but I'm looking in real-time fluoro. So you may not have that opportunity. So the way you may do it, that you may inject into the feeding tube itself, into the peg tube or the G tube, and then take a KUB like 10 minutes later. When I do an IR, I'm literally injecting and I'm looking with fluoro in real time, or the fluoroscopy machine, and I'm watching it go into the stomach. So sometimes I'm only using like a cc of contrast. All right. Oh, we're gonna talk about, and we did before too, but I want to reiterate this: peg tube versus G tube. What's the difference? I'm an IR. Don't come to me asking for a peg tube. Bonjour. We good? We good for today? Going once, going twice. I appreciate you guys. Case of the day coming up tomorrow. I'll make it a good one. We're gonna start getting into some crazy stuff. I'm putting together teaching files. Some of you guys may know. I'll post whatever number I'm on today. I think I'm on slide 1100, and I'm just like a third, fourth, fifth done. I don't even know. So yeah, it's a lot of sleepless nights, but I love it. I appreciate you guys. We're gonna pick this up tomorrow. You know the drill. Later.